Hello and welcome. My name is John Muchangi. I'm glad to invite you to our session in the first African Conference on Tobacco Control and Development. In our session today, we have 90 minutes and we have a total of 7 presentations. But first we will have 4 presentations, after which I will allow questions and answers. The abstract presenters are here at hand and will be waiting to answer your questions. So you can please, during the presentation or afterwards, you can submit your questions on the Wova app or on Zoom. Translation is also available at the bottom panel of both apps. In the first 4 presentations, we'll have Wasihun Melaku from Ethiopia. We'll have Dennis Malay from Uganda, Lojezo Masikini from the University of Bath, and Faston Goma from Zambia. My name is John Muchangi, and I am a science editor at Star newspaper in Nairobi. And I'm also a member of Kenya Tobacco Industry Monitoring Team in Kenya. And I will be your moderator for this session. So to begin with, I will call on Wasihun Melaku, a National Professional Officer, Health Promotion and Tobacco Control Focal Point at the World Health Organization in Ethiopia. Melaku will make a presentation on improvements in rolling out smoke-free environment regulation and their effectiveness in public places in Ethiopia. Welcome.
Thank you, moderator, for introduction. It is my honor to have this opportunity to share a success story related to tobacco control project in Ethiopia. My name is Wasihun Melaku, and I work for WHO Ethiopia as National Program Officer for Health Promotion and Tobacco Control Focal Point. In the next 5 to 7 minutes, I will be sharing you my presentation entitled Improvements in Rolling Out Smoke-Free Environment Regulation and Their Effectiveness in Public Places in Ethiopia. And my presentation follows this structure. I will begin with introduction, objective, methods, findings, and significance of findings and conclusions. I will be talking about a specific tobacco control project being implemented in Benishangul region. And this study is based on a 5-pronged tobacco control project that is in Benishangul Gumuz region. The objectives of projects have been set to create 100% smoke-free environment and contribute for reduction of risks of tobacco smoke exposure. Benishangul Gumuz is one of the regional states with a population of more than 1 million. As you see in the map, the region is highlighted in green and it borders with Sudan and within Ethiopia, Oromia, and Amhara regions. The prevalence of current tobacco smoke use in the region is 6.6%. There are several socio-cultural factors, including access to smuggled cigarettes, underpinning tobacco smoking habits in the region. As you see in the map, there are several red dots that show the incidence of tobacco smoke habits according to a local study. The 5 pillars of the tobacco control project include strengthening of multi-sectoral engagement, engaging law enforcers in checking compliance of public places, engaging health extension works to raise awareness of smoke-free environment regulation and prevention of harms of tobacco use in communities, strengthening media engagement for advocacy and public awareness raising, engaging civil societies to influence social and individual behaviors. To support coordination, planning, and implementation of the projects, a conceptual framework that takes into account critical inputs and key actors was developed to demonstrate the dynamics of interaction in enhancing local capacity towards achieving high compliance, improve demand reduction, and reduce the risk of tobacco use exposure. The study aims to analyze the impact of the 5-pronged tobacco control project in rolling out enforcement of smoke-free environment regulations and their role to effectively improve compliance of owners and managers of public places. 2 methods used in this study. One is monitoring of engagement of trained key actors empowered to mobilize and monitor compliance to smoke-free regulation. There are 5 actors, 72 heads of various regional and district sector offices, 78 law enforcers, 63 health extension workers, 72 members of civil societies, and 42 journalists. The second method used was cross-sectional direct observation of public places for compliance to smoke-free environment regulation using a compliance checklist. The checklist is used by law enforcers and it consists of 5 indicators: daily display of no smoking sticker, non-appearance of cigarette butts, ashtrays, active smoking, and absence of residual smoke. Key results of 492 public places subjected to exposure of smoke-free environment regulatory activities in 4 districts, 164 public places were found with display of no smoking sticker, 334 public places found with no cigarette butts, 405 public places found with no ashtrays, 397 public places found with no smell of residual smoke, and 403 public places found with no active smoking. This slide shows a compliance tracking table that is developed to show or to document the total number of public places checked and the total number of public places that fully meet the indicators, the 5 indicators, and the number of public places that have not met the indicators or that have partially met the indicators. Enforcement on smoke-free environment regulation covered about more than 250,000 population in 3 targeted district towns, 164 government, regional, and district public places or offices made 100% smoke-free environment. 3,750 households were visited through household education, health education. More than 900,000 people reached through local radio campaign in 4 languages, including Arabic, Gumzinya, Shinashinya, and Amharic. Significance of the results. Engaging key influencers served as key drivers for rolling out enforcement of tobacco control regulations. Integrating awareness of smoke-free environment regulation serve as a means for adoption of policies and legislations. Limitations: lack of sufficient data to determine proportion of public places that are 100% smoke-free environment is observed. Lack of data to assess the impact of educational activities and the number of people motivated to seeking health services have not been very well done. Conclusions: the study showed that a coordinated and integrated engagement of multiple layers of key actors who can play complementary activities are critical to improve rolling out of interventions and improve their effectiveness. References used: Ethiopia Global Adult Tobacco Survey 2016, a local study on substance use and associated factors among people in Benishangul Gumuz Regional State, Mandura Warda, Northwest Ethiopia, Ethiopia Tobacco Control Strategic Plan 2017, and a technical report of the total tobacco control projects in the Benishangul Gumuz Regional State. Finally, I would like to acknowledge Benishangul Gumuz Regional State, in particular Mr. Fakadu Balzo, Director of Regional Food and Drugs Authority, WHO at all levels, and the Federal Food and Medicine Authority. Thank you for listening.
Thank you very much, Melaku. Now we move on to the second presentation. The next abstract is titled, of course, there is conflict of interest, but you have to support the economy. Article 5.3 implementation in Uganda and the challenge of whole of government accountability. The others are Dennis Malay from the Center for Tobacco Control in Africa, Rob Ralton from the University of Edinburgh, Kellen Nyamurungi from Makerere University School of Public Health, and Jeff Collin from the University of Edinburgh. I will now invite Dennis Malay to take us through this presentation.
Hello, everyone. My name is Dennis Malay. I'm a research fellow at Makerere University and the Center for Tobacco Control in Africa. I'm glad to share with you my presentation titled Article 5.3 Implementation in Uganda and the Challenge of Whole of Government Accountability. Uganda is recognized as an example of good legislative practice, in part because it passed a comprehensive Tobacco Control Act. Uganda's law also includes provisions that mirror the FCTC guidelines on implementation of Article 5.3. But despite the efforts made, there are still documented ongoing challenges in minimizing tobacco industry interference. Therefore, difficulties in implementing Article 5.3 need to be understood in the context of broader governance challenges. Therefore, our team in Uganda conducted a qualitative survey involving 35 participants selected from government ministries, semi-autonomous agencies, and civil society organizations. Our data analysis focused on challenges of managing engagement with the tobacco industry across different government departments, as well as difficulties in developing effective whole of government accountability for tobacco control. So our analysis summarized 4 major findings. The first finding was that there were variable levels of awareness, uncertainty, and ambiguity about Article 5.3 across the different government sectors, with sectors within the mainstream health departments, as well as those involved in NCD control, having relatively high levels of awareness, whereas sectors beyond health had very low levels of awareness and often unsure about their roles as far as Article 5.3 implementation goes. The second finding was a popular view that sectors beyond the health departments or health ministry viewed the responsibility of implementing Article 5.3 as restricted to Ministry of Health, with many of them describing it as a Ministry of Health thing. So the third barrier that we identified was that there were competing mandates between tobacco control and economic growth. Therefore, the scope for multi-sectoral coordination mechanisms is constrained by the broader norm that the tobacco industry need to be supported in pursuit of economic growth. And finally, despite the challenges that I highlight above, we recognized that there was enthusiasm, especially from sectors beyond the health departments, to engage more with Article 5.3 and develop multi-sectoral coordination mechanisms for more coherent tobacco control. So based on our results, there are 2 key takeaway messages that I would like you to go away with. One is that our analysis highlights implementation challenges despite the existence of a comprehensive legislation. And 2, that promoting a whole of government engagement and accountability provides a powerful basis for coherent tobacco control governance. But despite all this, being a qualitative study, we believe that the data is not statistically representative, and this could be a limitation to our study. Thank you so much.
Thank you very much, Dennis. Actually, we clearly see this uncertainty and ambiguity among decision makers in Uganda about tobacco control governance. and how competing mandates and perceived difficulties in reconciling health goals with economic growth, how these impact accountability for tobacco control. So now we move to the next abstract, which is titled Some Progress Toward Alternative Livelihoods, the case of Malawi. This study is authored by Lonjezo Masikini from the Tobacco Control Research Group from the University of Bath, and Rosemary Hiscock from the Tobacco Control Research Group, also from the University of Bath. So Lonjezo, please welcome.
Thank you very much. Let me quickly share my screen with you. In the first place, I would like to thank you very much for this opportunity that you have given me to make a presentation on some progress towards alternative livelihoods, the case of Malawi. My name is Lonjezo Masikini. I'm a student at the University of Bath. I'm doing a PhD in social and policy sciences, now in my final year. As a matter of introduction, I would like to take you to WHO Framework Convention for Tobacco Control. Part 4 of the framework aims at the reduction of supply of tobacco, illicit trade in tobacco products, sales to and by minors, the provision of support for economically viable alternatives to tobacco production. But Article 17, which talks about the provision of support for economically viable alternatives to tobacco production, has not been highly discussed. And this is one of the reasons I'm making this presentation. As a matter of introduction, I would say there are two main producers in Africa, Malawi and Zimbabwe. Malawi is neither signatory nor party to WHO FCTC, and there are no regulations regarding tobacco production or even consumption. Tobacco is believed to be the main cash crop for most of the smallholder farmers. And as of 2018, tobacco contributed 71% of the forex for Malawi. But the share of the proportion of farmers that have been depending on tobacco has been declining for the past decade, from almost 16% to 5% within a decade. But there is little research that has been done to explain what has been the drivers to these shifts or explanations for the changes in rural livelihood activities, including and into outside tobacco. That was a strong driver to my research. Therefore, I wanted to explain how have political and institutional factors affected regional variations and the trends in tobacco leaf production and rural livelihood diversification in Malawi since 2000. To answer that overall objective or question, I have got 4 objectives that I would like to cover in my PhD. And one of them, which I call it the fundamental one, is to review evidence of the tobacco leaf production trends, as well as the rural livelihood activities over time. And this is in line with the sub-theme and track E of this conference, sub-theme 3 and track E of this conference, that talks about tobacco use surveillance for development. To do this research, I've been conducting key informative interviews as well as focus group discussions. I've also reviewed a number of literature, and I've also looked at the agricultural productivity estimates. The agricultural productivity estimates is the data that is always collected in Malawi on an annual basis for key crops. What did I find? These are just the preliminary findings, which I would like to share with you. Regarding crop production, I have to say there have been a very big shift in the sense that Malawians, or most of the smallholder farmers, are now growing maize, soya, groundnuts, as both food and cash crops. Among the non-food cash crops, of course, tobacco is the main one, grown by almost 5%. And again, cotton grown by 2%. But I said the share of the tobacco farmers have been declining. And to what are these farmers shifting to? Farmers are now shifting to cereals, root and tuber crops, and pears. The main crops being maize and rice, sweet potatoes and cassava, pigeon peas, groundnuts, and soya. And farmers from the central region said, if someone will not produce tobacco, then we'll produce either groundnuts or soya for cash. Farmers from the southern region said, for those who stopped growing tobacco, shifted to pigeon peas, and others shifted to rice and vegetables. In both of these regions, farmers have also started keeping more livestock. Of course, this does not mean that farmers were not keeping livestock before, but the proportion of farmers that are keeping livestock has been increasing for the past decade. Other livelihood activities, for example, potato trade, which have been there for a long time, have also been increasing. There are more farmers now going into different type of businesses than before. For the past 2 decades, we have seen bicycles and motorcycle taxis increasing proportionally. And even the number of households that are engaging in these type of businesses are also increasing. What does this mean, therefore? What is the message that we can take home? The key message here is that tobacco is not as important to Malawian farmers as the tobacco leaf buying companies often suggest. Food crops are far more important, both for consumption and for sale. Many livelihood alternatives exist out there. The trend is towards diversification from tobacco. Lack of sustained and consistent policies to promote the markets for alternatives hinders diversification out of tobacco. Ending tobacco production will be a major contribution towards protecting the environment. I thank you very much for your attention.
Thank you, Lojezo. Thank you very much. And finally, for this, before we have the questions, we will hear from Faston Goma. And regarding the question after Faston presentation, please continue to send your questions through the Wova app and also through the Zoom app. Faston's abstract is titled Impact of Tobacco Control Policies in Zambia, Findings from the ITC Zambia with 2 survey. Faston, please welcome.
Thank you very much. I am Faston Goma from Eden University, Lusaka, Zambia, making a presentation on behalf of my co-authors entitled Impact of Tobacco Control Policies in Zambia, Findings from the ITC Zambia Wave 2 Survey. Zambia ratified the World Health Organization Framework Convention on Tobacco Control in 2008, but to date, Zambia does not have a comprehensive tobacco control law. The International Tobacco Control Policy Evaluation Project, the ITC project, is an evaluation project that has been conducted in Zambia and 28 other countries the world over. The ITC Zambia survey evaluated the impact of Zambia's tobacco control policies and identified domains that require improvement. This was a face-to-face interview of a nationally representative probability sample of adult smokers and non-smokers. 2 waves have been done to date. The first was in 2012, the second was in 2014. Results from the ITC Zambia Wave 2 survey show the need for stronger policies in almost all domains. When we looked at tobacco use, we saw the need to ban menthol cigarettes and to increase tobacco taxes. 42% of smokers with usual brand smoked menthols, and actually 31% of them wrongly believed that menthols are less harmful than conventional tobacco. 51% of smokers bought loose cigarettes, and price was not a motivator to quit the habit. When we looked at smoking in public places, we saw a very high rate of smoking in public places, and therefore the need for a comprehensive smoke-free law. 74% of tobacco users noticed smoking in bars, and 64% of smokers actually reported smoking inside the bar during their last visit. When we inquired for intention to quit and the effectiveness of health warnings, only 27% of smokers plan to quit in the next 6 months, and only 24% of them noticed the single English text message that is contained on the Zambian cigarette packets. We also noted the greater need for better education on the harms of tobacco use. Among smokers, fewer than half knew that smoking causes stroke, and only 36% knew that it causes impotence. Among the smokeless tobacco users, fewer than half knew that smokeless tobacco causes heart disease, and less than 30% knew that it causes mouth, throat cancer, or gum disease. The good news is that nearly all Zambians, both tobacco users and non-users, support stronger tobacco control action. Actually, 88% of tobacco users and 90% of non-users agreed or strongly agreed that the government should do more to tackle the harm caused by tobacco. This study had several strengths. The only limitation was that which is general to self-reported measures that are subject to potential bias in recall. However, very few measures in this study required memory. We concluded, therefore, that tobacco control policies in Zambia are not effective. Although Zambia has been a party to the FCTC for over 12 years, its policies have not yet met the FCTC guidelines. There is therefore an urgent need for Zambia to implement these FCTC policies, which are actually contained in the draft comprehensive tobacco control bill that is currently under consideration. We also note the strong support that there is from even among the tobacco users for stronger tobacco control policies. These findings are a call, therefore, to action for Zambia to accelerate the approval of the comprehensive tobacco control bill. Many thanks to our sponsors, and I thank you.
Thank you very much, Faston. And now we get to the point where we have question and answers to all our presenters. All our presenters are here: Wasihun, Dennis, Lojezo, and Faston. The first question we have is for Dennis. It's from Pamela. She says, "My name is Pamela. I have a question for the Ugandan presenter. From your research findings, would you say that there's no multi-sectoral approach being used in Uganda as far as controlling tobacco use in the country is concerned, since tobacco control is viewed as a Ministry of Health problem?" And also for Dennis, there's still one more question from Uganda by the, he or she didn't give his or her name. It says, "I would love to hear Dr. Mali's recommendations on the situation in Uganda." Yeah, please take a minute and then we can listen to more questions for the other panelists. Thank you.
Thank you, John, for the wonderful moderation, and I thank the audience for those interesting questions. And indeed, while Article 5.3 is recognized as one of the single highest priorities to implementation of tobacco control globally, so our data highlights those intrinsic challenges that exist despite having a comprehensive law. And very specifically, we identify accountability as an essential feature for effective governance. And from our data, we see that, well, Uganda has a good law and the national coordination mechanisms have been in place for the past, say, 2 years, not so long ago. Did Uganda establish the National Tobacco Control Committee, but the level of awareness remains very low. we need to recognize the challenge of tobacco control financing in Africa and many other countries. Typically, there's a lot of support towards establishment of legislations, but then it doesn't go far beyond that. So even the national coordination mechanisms, the National Tobacco Control Committee struggles to implement or create awareness beyond the health sector or institutions that are involved in NCD control, or even NGOs that are involved in NCD control. So it appears that a lot of work revolves around those few spheres, and as Dr. Ahmed said yesterday, that we tend to speak to ourselves, and as a result, we create chambers, echo chambers, as opposed to real impact within society. So we need to create or support whole of governance approaches in order to turn tobacco control as not only a Ministry of Health responsibility, but a responsibility for the society as a whole. Thank you so much.
Thank you very much, Dennis. I'm still waiting for more questions, but Wasihun, from your presentation on the progress in rolling out smoke-free regulation in Ethiopia, we've seen from your presentation we saw some progress, but what are the main drawbacks?
Thank you, John. Do you hear me?
Yes.
Yeah, thank you for this question. As I tried to explain in my limitations in the presentation, the main challenges are regarding gathering of data and also information from beneficiaries, for example, the community at large. So the law enforcers, health extension workers, and members of the civil societies are expected to do more. They expected to be motivated more and gather data to understand the real impact in terms of, for example, the number of people seeking demand for health services, also the needs of public places and their challenges on how to effectively set their public places 100% smoke-free. So these are just kind of data and information that we need to have more so that we can update or revise our strategies to improve our tobacco control program implementation. Thank you.
Thank you very much, Wasihun. And we have also a question for, I think this is for Lonjezo. It says, my question to the third panelist, that should be you, Lonjezo. In addition to the main driving factor, diversification, has the study looked into factors such as perception of risks to health, environment, etc.? This question is from Wasihun Belay.
So, sorry, do you mind if you can repeat the question?
It says, in addition to the main driving factor, diversification, has the study looked into factors such as perception of risks to health, environment, etc.?
Thank you very much. That's really an interesting question. Yes, of course, not necessarily looking into those issues in detail, but I have to mention that during the study, it was really mentioned that yes, when it comes to the environment issues, tobacco remains one of the crops that is really affecting the environment, and that came out strongly as tobacco uses a lot of trees, a lot of yes, there is a lot of cutting down of the trees, leading to deforestation. Going even beyond the environment issues, I have also to talk about the child labor. It also came out strongly, right? Of course, this has been reported many times by other scholars, but even though I did this research recently, child labor remains a serious issue. So my research also tackled, also exposed those issues that came out. I have also to take this to take advantage of this opportunity to say, yes, there is diversification that is taking place in Malawi. Should we be happy, therefore, that we are going towards diversification? The answers are one, yes. The other answer is no. The answer, yes, because farmers already have started diversifying, which means it makes it easier for us to come up with interventions that can help them not even to go back to tobacco, but to stay in those into those crops which they are already involved in, or even other activities which they are already doing. We shouldn't be happy because there is no intervention that has been done for farmers to move out of tobacco, which means the tobacco industry still has the power to come up with their own strategies, which they have always been using. For example, the use of the prices to take the farmers back into tobacco farming. So we are in a dilemma here. We need to think of what are the key strategies that we need to do so that the farmers by themselves, although they shifted from tobacco, they should not even come back to tobacco farming. Those are the issues that we need to be thinking about. Because another thing which I have to say is we have seen farmers moving away from tobacco farming, but the land allocation to tobacco remains relatively the same, although it has declined a little bit, but it remains relatively the same, which means farmers now just expand. We have got more farmers moving out of tobacco. The few farmers that are in tobacco farming are increasing the acreage. So that's also an area that has to be considered. Thank you.
Thank you very much, Lojezo. Moving to, we have two more questions. First one, we saw only, only 24% of the smokers said they noted the warnings on the cigarette packets. I wanted to know how large are these warnings, and do you also have the do you also have the graphic warnings on the packets? And also there's a question here: what is the situation regarding the non-smoked products in Zambia? I feel this kind of data would drive your efforts for the law more. Thank you. I think we can take those ones, and then we go to probably the last question.
Thank you very much, John. And those are very, very interesting questions. In terms of the warning signs on Zambian cigarette packets, so far the law allows for just a text warning message. There's just a line there in English which reads, "Tobacco is harmful to health." That is all that is required. And it takes really less than 30% of one surface of the cigarette packet. And the tobacco industry has been very crafty. They try to make it as small as possible and to put it at the bottom of this packet or sometimes on the sides of the packet. No wonder very few people see it. And even then, the message is in English, and a very, very small proportion of Zambians actually read English. And so, again, it doesn't affect the tobacco users that much in seeing it as a warning sign. And so, really, I think we are now pushing for the graphic warning signs because we think that, they would convey the messages better. So this is one of the evidences we have for pushing for the graphic health warning signs to be put on our cigarette packets. In terms of non-smoked tobacco, we still have a small proportion of the population that uses it. We think that now we are riding probably to about 10%, and mostly in women. Most of the tobacco users in Zambia use smokeless tobacco, and this comes in form of snuff. Most of it is traditionally produced, and so we really don't have commercial versions as yet of these smokeless tobacco products. And so I think when they come up, we will see what the ball game will be like at that point. Because even now, I think we are having a problem with roll your own tobacco, which does not come in these commercial packets. there is no way of putting any labels, any health warning labels on such tobacco. Again, I think we need to try and see how well the regulation will come in to try and see if we can use the packaging as really conduits for getting information to the people who use tobacco. Thank you very much, John. I hope I've adequately answered the questions.
Thank you very much, Fastone. And Shelley Kansabe, I have your question here, and also I have a question on the Wova app from Dushime. It's in French. I'm waiting to get a translation for those two questions, and then Dr. Dennis Malay can answer them, but after the next presentations. So after this, because of time, we really started late, and we want to go to the last three presentations, and then after that, we can also have some more questions. So I still encourage you to send questions on the Wova app and also on the Zoom app. And I now welcome a presentation from Susan Kai. This presentation is titled Evaluating Tobacco Control Policies in Kenya. Susan, welcome.
Thank you, John. Hi, my name is Susan Kai. I'm a research scientist, and I'm going to share these findings on behalf of my co-authors. Kenya ratified the WHO Framework Convention on Tobacco Control in 2004. The ITC project that I work for is an evaluation project that has been conducted in Kenya and 28 other countries. The aim of the ITC Kenya survey is to evaluate the impact of Kenya's tobacco control policies and identify areas that still require improvement. So far, we have done 2 waves of the survey. Wave 1 was done in 2012, and wave 2 was done in 2018. There are many results from these findings, but I'll just focus on the wave 2 findings. Menthol use is common in Kenya, and 66% of smokers wrongly believe that menthols are less harmful. This is concerning because, as you know, menthol masks the harshness of smoking cigarettes, therefore making it easy for people to begin smoking. 82% of the smokers bought loose cigarettes, even though it is banned. And generally, we can say that cigarettes are highly affordable in Kenya. Smoking is high in bars, and 69% of tobacco users noticed smoking in the venue in their last visit, and 65% of these smokers actually say they smoked in the venue when they were last there. When you look at quit intentions, only 16% of the smokers plan to quit in the next 6 months. This is very low, and therefore there's need for stronger support for smokers to quit. Smoking remains socially acceptable in Kenya, and among 11 ITC LMICs, Kenya has the lowest percentage of smokers who think that society disapproves smoking. So this needs to be denormalized. In 2016, Kenya introduced 3 pictorial health warnings, and this led to a significant increase in the effectiveness of health warnings. If you look at the figure on your right, the second dotted line shows when the pictorial warnings. With 1 and wave 2 was done after. So it gives us a pre and post measures. And you can see from these figures that 6 out of the 7 health warning effectiveness indicators significantly increased after the implementation of pictorial health warnings. In most of the time, the tobacco industry makes the claim that tobacco users are not interested or do not support stronger tobacco control action. But when you look at this bar graph, you can see that 80 to 90% of the tobacco users represented by the red bars actually support stronger tobacco control action. And you can see it's very close to even the non-users. There are several strengths and limitations of this study. One of the strengths is that the design and the measures of the ITC survey permits rigorous evaluation studies of FCTC policies. One of the weaknesses is that the measures are self-reported, and you know that this can be subject to potential bias in recall. However, most of these questions that we asked the respondents were things to do with their beliefs and support for stronger government action, which may not necessarily have to rely on recall. So in conclusion, I would say that Kenya has made good progress in the FCTC implementation, but the findings from ITC highlight areas where there's need for improvement or stronger action. For example, Kenya needs to raise awareness on the harms of tobacco use and bad methods to discourage smoking initiation. It's also important to strengthen enforcement of the ban on sale of single cigarettes and implement comprehensive smoke-free laws without any exceptions. Kenya needs to simplify the tobacco tax structure and implement regular tax increases to make tobacco products less affordable. It's important also to enhance the access to affordable cessation services in Kenya. Kenya also needs to implement the full set of the 15 pictorial health warnings on tobacco products and increase the size of warnings to 50% of both sides of the pack. And also, it is very important that Kenya considers plain packaging like in other high-income countries. And I know that Mauritius is in the process of implementing plain packaging. I'd like to thank our research partners and also our research funders. And thank you so much for listening to my presentation.
Thank you very much, Susan. And now we move to Benawe Lawrence from Makerere University, who will make a presentation of the results of a study titled Prevalence and Determinants of Secondhand Smoke Exposure among tour drivers and guides. This is a cross-section study in Kampala, Uganda. So I now want to welcome to Benawe.
Hello, attendants of the first conference on tobacco control and development in Africa. My name is Benawe Lawrence, a student at Makerere University School of Public Health, doing a master's in public health and tracking epidemiology and biostatistics. I gradually received funds from Center for Tobacco Control Africa to carry out a study on the prevalence and determinants of secondhand smoke exposure among tour drivers and guides. This study was done in Kampala in Uganda. The background of the study is that most countries have come up with laws against tobacco, the smoke-free zones, but this practice continues to exist. And this exposure is linked to diseases, disability, and premature death. Over 600,000 people are lost every year. And this is because of this exposure. So we had to look at this situation and considering that there is always an observation of secondhand smoke exposure among tour drivers and guides. But since this situation was not known or not documented, we had to carry out this study so that this can be properly documented. So this study aimed at the investigation of the following objectives. The first was the prevalence of secondhand smoke exposure among the tour drivers and guides. The second one was that to determine the determinants of secondhand smoke exposure among tour drivers and guides. The third was to determine the prevalence of secondhand smoke exposure, of the prevalence of e-cigarettes among tour drivers. And the fourth one was to determine the perception, knowledge, and attitude on secondhand smoke exposure and cigarettes among tour drivers and guides. Therefore, the method we used for the study was mixed research method, and we used a semi-structured questionnaire to pick both specific information and also the in-depth interviews. And it was done, like I said, in Kampala metropolitan area, and we used a multi-stage sampling method, whereby we had lists of the companies, tourism companies from their website, and then we had to look at, we sampled out the companies that we needed, then looked at the list of staffs, and then also we sampled the staffs that participated in the study. So this was a cross-sectional study and all the information was picked at the point in time. So the population that we studied were the tour drivers and guides in Kapempeto area, and we contacted over 379 participants, which represented a 98.7%. And this was good enough to give us robust data. So results, we found that 75.7% of the tour guides and drivers were exposed to this second smoke during the course of their duty, and 13.5 had experienced a client who smoked an e-cigarette in the vehicle. And when we did a multiple regression method, the regression model, we found that the time spent with the smart client and the frequency of time socializing with the smart client at a coffee shop were the key factors or variables that were most associated with this practice. And when we looked at the qualitative information, we found that most drivers could not stop these people or their clients from smoking because they thought this was against the hospitality spirit, and they would be termed as having poor customer care and they would lose business. And since we determined these two factors, then we had a justification to target a reduction on social time by the tour drivers and guide. That was our main recommendation. Like we have this put across, and also we have the targeted policies by Ministry of Health to prevent this kind of exposure by designing policies and guidelines and SOPs for this business, which of course we know as in Uganda, it's one of the highest income earners for the country. So it needs all the attention that it requires. The limitations were there, and these included the recall bias, considering that we looked at the past experience of the participants, but this one was reduced by looking at the number of days, and we had to look at the 30 days before the study. And then we never measured nicotine and metabolic cotinine, which are markers for this exposure. But the questions we used were from other tools like STEPS and GATS, which are standard questions, and we think they gave us the right information. Then this was just a cross-sectional study. We never did a longitudinal study, and we couldn't determine the health effect, the effect of this on the health of the drivers and guides in the long run. And also we couldn't determine what this exposure, its effect on the behavior of the drivers and guides in line with smoking. Thank you so much for listening, and I wish you good deliberations as we go on with the conference.
Thank you, Lawrence. Clearly, based on the demonstrated high exposure among tour drivers and guides, there's actually a need for targeted policies by the Ministry of Health to prevent this kind of exposure. So finally, we move to our last presentation for this session, and this is from Alina Madar. Alina will take us through the national policies regulating e-cigarettes in Africa. Thank you and welcome, Alina.
Thank you, John. Hello, my name is Alina Madar, and I'm presenting on behalf of my authorship team at the Institute for Global Tobacco Control at the Johns Hopkins Bloomberg School of Public Health. Today, I will be presenting on the national policies regulating e-cigarette use in Africa. E-cigarettes are a product that has truly grown in popularity globally, the highest prevalence of use being in parts of Europe, Asia, and North America. Globally, the retail value of e-cigarettes is estimated to be greater than 21 billion USD, with year-over-year sales projected to grow rapidly in the near future. At IGTC, we have been tracking e-cigarette policies for years to try and understand how countries are using policies to classify, ban, or regulate these products. In some countries, such as the US, e-cigarettes have been deemed tobacco products and are regulated similarly to cigarettes, for example. In other countries, such as Canada, legislation has been passed specifically to regulate e-cigarettes, and these products have their own corresponding legal classification. Today, I will summarize the information about policies in African countries used to regulate e-cigarettes from our last policy scan. I'll start by sharing information on our policy scan methods, e-cigarette classifications, and what types of regulations or policy domains are being used. How do we identify policies being used to regulate e-cigarettes? We take an active approach to identify policies at the federal or national level. First, we conduct surveillance of media to identify any news reports, discuss policies or policy changes. Second, we reach out to in-country experts, such as people who work for a Ministry of Health, or in some cases, people working in the NGO sector in tobacco control. We ask for policy updates on either new policies or amendments. Once we have copies of relevant policies, we review them at IGTC and determine how e-cigarettes are being classified and what regulations are in place to control their sale and use. We then send our classifications back to our in-country expert who reviews our work and checks it for accuracy. Once we have clarity on the policies, we share results via our global policy scan. How do we make our categorizations? First, we identify what kinds of policies being used. This can come in the form of new or amended legislation, decrees, or other regulatory mechanisms. Then we identify how e-cigarettes are classified under a particular country's policies. Often, e-cigarettes are classified as tobacco products. Other countries have pathways for these products to be classified as medicinal or pharma products, or a combination of multiple classifications. Finally, we determine the policy domains that fit each country's policies, domains like minimum age laws, sales bans, marketing and packaging limitations, etc. As of our last complete policy scan in February of 2020, we identified 7 countries in Africa that had policies regulating e-cigarettes. In general, e-cigarettes were either classified as tobacco products or electronic nicotine delivery systems, or ENDS, with only South Africa classifying e-cigarettes as medicinal and regulating them accordingly. Additionally, policies in the Gambia, Togo, and Uganda apply to nicotine and non-nicotine e-cigarettes. In our scan, we report regulations by policy domains that restrict or ban advertising, promotions, and sponsorship, distribution, importation, manufacture, and sale of e-cigarettes. Togo is the only country that has minimum age and clean air laws, as well as a tax on e-cigarettes. While about half of the countries report restricting distribution and sales activities of e-cigarettes, and another half report restrictions on advertising, promotion, and sponsorship, only 2 countries report restrictions in both of these major policy domains. We acknowledge that our study is limited to the information we find from our media scanning and in-country contacts. A notable aspect of our policy scan is that it includes a feedback process. If we are missing information or need to update or change information, we encourage sources to reach out to us. In total, we identified e-cigarette policy information on 7 of the 54 African countries. Overall, these countries had bans or restrictions on e-cigarette advertising, sales, and distribution, or a combination of these domains. Only 1 country classified e-cigarettes as medicinal in nature. It is notable to point out that no countries identified had policies regarding child-safe packaging, health warning labels, restrictions on e-cigarette ingredients, flavors, and nicotine levels, or any other reported safety and hygiene requirements. Continuing policy scans like this is important because consistent monitoring of the status of e-cigarette policies in Africa is necessary to track the evolving product and policy landscapes of e-cigarettes on the continent. With comprehensive monitoring, public health practitioners can then develop and adjust their policy strategies to help advance the global tobacco control agenda and meet sustainable development goals. Thank you for your care and attention during this presentation. Together, we can advance tobacco control research and policy in Africa.
Thank you very much, Alina. Clearly understanding how these products are classified and regulated is important to improve public health surveillance and evaluation. Yeah, now I want to move to the last section for question and answers from our audience, to our last three presenters. But before we go to our last three presenters, there was a question pending for David Mallet. David, I hope you're still, I can see you're still here. We have two questions for you. One that was in French, but I have received the English translation now. And it is, are there figures in the fight against tobacco in general on East Africa, or in East Africa community, or studies done here in the East African community? So this question is for you, and also Lawrence can add. And there's still one more question for you from Shali Kansabe. Dr. Mallet, where should future research focus on regarding Article 5.3 in the light of your findings? So you can answer that, and then we go to questions to our last three presenters.
Thank you so much, John, for those interesting questions again. So I'll start with the question posed by Shali Kansabe. And on future research, I should also reveal that my study mostly based on analysis of national level interviews, but it indicates that, you know, we need to understand the drivers of coordination at national levels. And by this, we need to explore both horizontal coordination across the different government departments, as well as barriers to vertical coordination. And by vertical coordination, I imply, you know, policy communication at the different levels of government. For instance, looking at the districts level, sub-county level, and how these interact with institutions that operate at a national level. There's very limited data on how, you know, Article 5.3, as well as, you know, policy communication looks like at the different levels. But we also need to explore financing, sustainable financing mechanisms for tobacco control. As generally, in the Ugandan context, our law is not very clear on how we should promote or increase awareness about tobacco control legislations as well as programs. But then when what our data shows is that stakeholders or policy actors are always concerned about the availability of funding. But then we know that tobacco provides a unique opportunity to generate financing for tobacco control intervention through raising tax. And if we can raise the tax and ring fence it for tobacco control interventions, that has been proven to work. But then why are we not doing it? Could we conduct studies to explore that further? And there was a question on what has been done at the East African level. Recently, I attended a harmonization meeting of the East African community on cigarette product standards. So this is an effort that is ongoing at a regional level, but then we also have an Africa body called ARSO, which oversees as well and provides guidance to different national regulatory authorities on issues regarding tobacco regulations. So we need to strengthen all these efforts and see where that takes us. But there's a lot of ongoing work. We need to embrace them and make ourselves available as well as our institutions towards this common cause. Thank you so much.
Thank you very much, Dennis. And I think Faston, I hope you're still with us. We have a question. There's a question for you here from a journalist from Zambia, Annie Zulu. She asks, my name goes to Mr. Goma. Do you think the Zambian government is giving the much needed attention to tobacco control? Is there anything being done to push for stronger policies? I think you can answer that shortly, and then we go to our last three presenters. I'm not sure if Faston could hear me, but as we check whether you're still with us, I'll go to our last three presenters, and we have, that's Susan Tugenawe and Alina, and starting with Susan, your presentation on the progress on implementing the FCTC in Kenya, we saw a lot of progress, but we still saw there are many gaps in implementation. I wanted to know what are the drawbacks, what's the cause of these slowness in implementation of the convention in Kenya?
Thank you so much, John, for that important question. I think some of the presenters have raised, I think it was Dennis who talked about the fact that there's issues to do with funding with any work regarding tobacco control. Sometimes there's not enough attention to it, or there's not enough funding to be able to support the work that needs to be done. So Kenya has made quite some amount of progress, but there's still a lot of work to be done. And also another second challenge is there's a lot of pushback with the tobacco industry. As you remember, when the 2016, it was initially called the 2014 tobacco control regulations that came in, in the actual bill, they were supposed to be implementing 15 pictorial health warnings. And up to now, so far, they've only implemented 3 of them, and that's because of the pushback from BAT. So there is a lot of interference from the tobacco industry. I know you've probably been seeing the media, what the behind the scenes that the tobacco industry has been doing to ensure that the enforcement and of the tobacco control laws are not implemented as they should. So, for example, one of my recommendation is that we can see that in most of the African countries where literacy is an issue, you really need, like a good example is like the text warning in Zambia is only 30% of the pack, and then it's in English. And of course, as Faston said, many people may not be highly literate in terms of speaking or reading English. So really, what should happen is that, I know you did ask about, I think there's a journalist that asked about what Zambia is doing, and I know that they're still fighting and pushing for the comprehensive tobacco bill to be implemented, and there's still a lot of pushback from the tobacco industry. So basically what I'm trying to say is that so sometimes there are certain aspects where the government will, to be able to support implementation of tobacco control policies, can sometimes be interfered with by the tobacco industry, and sometimes there's not enough funding. But otherwise different. Kenya, when I compare Kenya and Zambia, because the ITC project has longitudinal surveys in both countries, there's more progress going on somewhere in, more in Kenya than Zambia. We are also in Mauritius, and as you know, that Mauritius right now is in the process of implementing plain packaging. So anyway, I don't want to take a lot of time, but there's also the willpower from the government part, and I know that Kenya has been quite supportive, but also there's a lot of pushback from the tobacco control industry, pushing back to make sure that, of course, their purpose and their main interest is profit. It's not really public health to protect the lives of Kenyans or Zambians or any other person. So I think, yeah, there are many things, but yes, I do acknowledge that Kenya is making progress when I compare with other countries. So I don't know, John, whether you need more information, or I know, or that's adequate. Thank you.
Thank you, Susan. And there's still one more question for you before you go. How is the association of increased graphic health warnings coverage? I think the question is, how was the association of increased graphic health warnings coverage to demand for cessation services? Did you understand
I think the question is, I think
Yes.
I read it. It's a bit confusing. Basically, I think what I was presenting is that one of the progress that we have seen is when the switch happened from text warning in 2016, when Kenya switched from just the text warning to the 3 pictorial health warnings, we saw that there was a significant increase in what we call the health warning effectiveness variables or factors, and some of them are things like when we ask people, before the implementation of pictorial health warnings, when they were text warning, we asked them that, in the last month, have you noticed the warnings? Have you read them? Have the warnings made you more likely to quit? Have they made you more likely to, to forgo cigarette, etc.? So we asked the question before the implementation of pictorial health warnings, and then we asked them after the implementation. And basically what I was saying in my slides is that we saw that, yes, the pictorial health warnings, even though there were only 3 of them, that they have been effective in terms of what you call the health warning effectiveness indicators that we measured showed that they were significantly increased. In terms of the size, Kenya, I think it is 30%, 50%. We are recommending that it would be great, like in other countries, to increase those pictorial health warnings to at least 50%. So I know the question was a bit confusing because Kenya only switched from text warning to pictorial health warnings. They haven't really increased the pictorial health warnings, and that's what we are recommending, whether they could be able to increase them. The question you also asked is, I think, in terms of cessation, I think clearly one of the findings that we got from our study is that the quit intention in 2018 was only 16%, and that is really low because quit intention is a great predictor to know whether people will move on from just intending to quit to actually quitting. And I think I would say that so far that it is still low. That was 2018. We haven't gone back in 2021 to see what is happening, but I'm sure that with the switch of the pictorial health warnings, there must have been some indication of cessation, which I have not, I haven't shared about it, and we haven't looked at it. But what we are trying to say is that the quit intention in Kenya is still very low, and that means the government needs to be able to enhance their cessation services to encourage many smokers who would like to quit, because when we ask them about quit attempts, there are many people, about maybe 40% said yes, they would like to quit. But then, I mean, that have made a quit attempt, that we asked them, have you ever tried to quit? And we had about maybe 40% of the people saying, yes, I would like to, I have attempted to quit, but have not been successful. So yes, we would need more enhancing of cessation services that the government could provide so that we support these people that either have ever tried to quit or even are intending to quit. In terms of increasing cessation, it would be great if they can be able to increase the size of the pictorial health warnings, because we've seen it in other countries where pictorial health warnings have been increased in size, like in Mauritius, and that helped a lot with cessation. Thank you.
Thank you. Thank you very much, Susan. We have one question, I think this for Alina. To the presenter on e-cigarettes for South Africa, I am interested to know what kind of medicinal product are e-cigs classified as, e.g. prescription only or pharmacy only, etc. Are there any restrictions or not on where they can be accessed and the circumstances under which they can be accessed? Thank you. Alina, do you want to take that?
Yes,
take on
sorry
that
about
one?
that.
Okay.
Hi, thank you so much for your question. At this time, I don't have the information right in front of me, but I've posted a link in chat to everyone to our policy scan. And if you locate the country, South Africa, there's the complete law details detailed on our website. And if you think that anything is incorrect or might be wrong, please feel free to email me and reach out. And I would love to discuss where we found our contact information from and where you have your information from as well. Thank you.
Thank you, Alina. And Tubenawe, from your presentation on the exposure to tour drivers and the guides, how do you consider? Does the study consider how you can reduce the exposure? Like, what are the ways, some of the ways through which we can reduce exposure to the tour drivers and the guides?
Thank you, John. For this group of the tour drivers and the guides, what we need the most is the legislation, because the like e-cigarettes are illegal in Uganda. So enforcing the law would protect these tour drivers and guides, but also empowering these tour drivers and guides to say no. If you are in the vehicle driving a tourist or a client, you shouldn't smoke in the vehicle. But because they can't say no, they fear losing a job, they allow the person to smoke in the vehicle. And then it exposes everyone who is in the vehicle because they don't have much say. And also, we have to look at the sensitization. How much do these people know about e-cigarettes? Maybe because some of the research were showing that they thought these cigarettes were less harmful because they have that good scent. And they think it's less harmful, it's filtered, and at the end of the day, it might change their behavior towards smoking the electronic cigarettes. So they need more sensitization. The Ministry of Health has to come in, the focal point desk, to come in and come up with the proper strategies, sensitization strategies on how to empower this group, because you'll find that these tourists are in a group of hospitality business. And also a study which was done on this showed that 62% of the people who visit these hospitality businesses get exposed. So it's more correlated, and even in the results from Kenya, you see there is much correlation in the hospitality sector. So it needs a lot of attention and enforcement and removing all the smoking zones that are demarcated and make sure there's 100% free smoke zones in the country. Thank you so much.
Thank you, Tubenawe. I think I do not have any more questions from the Whova app. I still, maybe we still have 2 more minutes. If you have a question to our audience, if you have a question, you can still send on the Whova app or on Zoom app. And to the presenters, yeah, we have one question before we go to the presenters. I think this is still for you, Tubenawe. If it is company policy, why not have a smoking forbidden stickers on car so that the driver won't have to say anything to potential smokers? I think you can answer that, and then slowly we finish.
Thank you so much. The study also looked at that point. It also found that some cars had stickers, but the same drivers will tell you they get exposed. But we also looked at who is responsible for putting up these stickers, and they noted that it's the company owners to put on the stickers. And if the company wants to fears losing the business, it will not put much restriction on the business, considering that this business is even being hit hard. So they might not want to put more restrictions on their business. So the most important thing is to empower these drivers and the guides, and also make sure that the e-cigarettes are not imported in the country, and also the smoking, the 50-meter distance for smoking is respected, and these drivers know about it. So the law must be brought down to the community itself, to the tour drivers and guides, to understand what are their rights, and also how they can defend themselves in such circumstances. Thank you so much.
Still one more question for you. I'm made to understand the study was done in Uganda. This is a question, but can we see the findings are regional representation of the situation? I think regional, probably this means the East African region. That's for you, Lawrence.
The regional representation, I can't say much about that, but someone who presented data from Kenya, you saw that e-cigarettes were at around 13%. And also this study also found the same range. And if you look at the tourism sector, it was in 60, the secondhand smoke exposure was in 60. And this study showed that it was at 75. So there is that correlation, and showed that there is the way our laws are not implemented that tight. And it could be, I don't know about Rwanda, but for Kenya and Uganda and Tanzania, things, the laws are usually soft, and it's very hard to implement such laws because of our politics. So I still think empowering the communities about the dangers of this practice would be better than only looking at the law, because the law has been there, but as someone showed from the policy and asking the CSOs, the law implementation is still low, the enforcement is still low, and even the budget might not be there. So we still need to look at sensitization and also having clear policies that trickle down to the community. Thank you so much.
Thank you, Tubenawe. Annie Zulu, you sent the question for Fastone. If you can please send me your email on the Wooba app, I can forward the question to Fastone, and then we can get an answer for you. And now to our presenters, Susan and Alina, do you probably have some comment to us, and then we can finish? Some final comment? Susan, Alina, and any of our presenters in the first session?
Thank you so much, John. I just wanted to say thank you very much for the opportunity to present our findings. I think there is still a lot of work that needs to be done in the African countries in terms of tobacco control. And I think I'm really excited about having this First Africa Tobacco Control Conference because it gives us the opportunity as researchers, as advocates, as policymakers to work together as a team in Africa, because we've not had that opportunity to work together. It's been like there are about 54 countries in Africa and everybody's doing their own thing in their own corner. So I think it will be there'll be great synergy to be able to work together and partner and see what other countries are doing and work together as a team for this one common goal, to be able to protect our citizens from tobacco, which we know is, the leading preventable cause of death, which can be prevented. So I think it's really excited. I mean, I'm really excited myself that this is an opportunity that we can work together, and I'm calling together. The 54 African countries, that we come together and work and fight together for the sake of our children and our citizens. Thank you so much.
Thank you very much. Wasihun, something to say? I see you have your hand up.
I just want to thank you, John, as moderator, and everyone and panelists. Maybe will there be any possibility to access all presentations or abstracts? Thank you very much.
Thank you, Wasihun. And Lojezo, I see also do you have something? Would you want to say something, and then we finish?
I think most of the presentations I've really enjoyed them, and I've heard a lot about what is happening in other countries. I think I would just say maybe on behalf of from Malawi, there is little that is really happening from Malawi when it comes to tobacco control. Although we have got few people, or the proportion of smokers has been reducing, but I still feel like there is more that has to be done. I would say this is my opportunity to request how I can network with other people and how we can really develop some of the interventions to continue reducing smoking, to continue to reduce smoking. But at the same time, again, I talked about the diversification. We need strategies that can help smallholder farmers to completely move away from tobacco. This is an area that will also need networking, ensuring that we are able to support our smallholder farmers, be able to increase their income through other value chains. I think if there are other people that we can coordinate on this, I'm ready, we can always link up. Thank you very much.
Thank you very much, Lojezo. Dennis Malay, your last word.
Well, thank you so much, John, for giving me an opportunity to share some of the work that I and my group have done. I would like to re-emphasize the need to promote a whole of government accountability, because I believe that it's a cornerstone to implementation of tobacco control policy. Thank you.
Thank you very much. And finally, Alina, and then we can wrap up.
Great. Thank you so much, John. It was so wonderful to meet all of you panelists today, and thank you for everyone to coming to listen. I would also like to emphasize that the information that we have on e-cigarette policies are very limited in Africa. And so if you or any of your research teams of those listeners or other panelists know anything else or have any other corrections to the data that we have, I would absolutely love to reach out. I have my email in my chat because it's so important for all of us to work together to combat tobacco control in Africa. So thank you very much.
Thank you very much. And to our audience, we very thankful. And I want to wish you our fruitful engagement throughout the rest of the conference. And have a good day. Bye-bye.
Thank you. Bye.